So I'm going to talk a little bit about epidemiologic research on cannabis use in health, specifically some recent findings relevant to US military veterans. And before I begin, I really want to acknowledge my collaborators. I've been fortunate enough to work with really great collaborators, and all of this is a team effort, not an individual effort. And I truly am thankful to all of them, and the success that I have had has been because I've had great collaborators over the years. And I also like to acknowledge and thank the sources of funding. And I don't have other conflicts of interest. So just to start, I want to give us an outline so that we're all on the same page of kind of what I'm going to run through today. I'm going to start by giving a brief context of cannabis use in the US, then talk a little bit about other key contextual issues in the US related to cannabis. Then I'll talk about medical cannabis and relevance to veteran health. Specifically talk about what some potential medical benefits and harms are of using cannabis and what we know in the current state of the evidence. Then talk a little bit more about some of the recent work that I've done in especially epidemiologic work and national surveys, and then findings, longitudinal findings from a study, Mark Ilgen's study of medical cannabis, especially new longitudinal work that we've done, and then kind of give a wrap up of overall discussion and limitations and future directions. So to begin, I'd like to just talk a little bit, just give a very, very brief overview of the context of cannabis use in the US. And so what I'm going to talk about here, and some of my national studies relate to the National Survey on Drug Use and Health. Many of you are aware of the NSDUH, but just to provide an overview, it's an annual cross-sectional survey. It began in 1971, and now it includes around 70,000 participants, and it provides nationally representative information on tobacco, alcohol, and other drug use. And it also asks other key indicators of health. And so it's a really rich resource. Many of you probably who are in graduate school may be using it for your thesis or dissertation. And so I just wanted to kind of make sure that everyone is aware of this rich resource. So when we think about how many Americans use cannabis, we can see that in the most recent year of data that we have, around 48.2 million Americans use cannabis, and that represents around 17.5% of the overall US population age 12 and older. And you can see that the prevalence of cannabis use is greater than any of the other drugs that we typically study. This is similar with respect to veterans. You can see here that the prevalence is a little bit lower, 12.8% in the past year in 2019. That is roughly 2.6 million veterans have used cannabis in the past year. And similarly, other drug uses, the prevalence of other drug use among veterans is much lower. So when we look at trends in cannabis use, one of the key things that we've been focusing on and examining and trying to understand is the increase in cannabis use over the past 10, 15 years. And you can see that around 11% of individuals used in 2002, and now in 2019, around 17.5% have used in the past year. I don't have specific information on veterans here, but in our surveys using the National Survey on Drug Use and Health, we know that around 9% used in 2014 in the past year, and that's increased to around 13% in 2019. So similar trends have been observed in the veteran population as well. So what else is going on in the US during this time period? So right now I'm going to talk a little bit more about and give a descriptive overview. But there is also empiric work in this area linking some of the things that I'm going to talk about to the increases or rises in past year cannabis use and trends in increased cannabis use. So just be aware of that as well. So with respect to one of the things that's also happening is that the frequency of cannabis use is increasing. So the mean number of days that people who use cannabis use is also increasing. Also daily or near daily cannabis use has also been on the rise in the past 10, 15 years. So not only is the prevalence of past year use increasing, the frequency of use is also increasing in the general population. We also know that there's been really rapid rises in the average THC potency or cannabis potency in the US. And this has been, some of these studies have shown that DEA seized cannabis has risen in terms of potency. The other thing to note here is that when one goes into a dispensary, you can find cannabis that has even higher potency, either in higher THC percentages, 50, 60% THC. And this doesn't include things like dabs that are very, very high potency with respect to THC content. And so the other thing to think about when we think about potency is the potential for developing cannabis use disorder, and whether this rise in potency is associated with increases in potential liability of cannabis use disorder. Increasingly, cannabis has also been perceived as low risk or less risky, and this has been also linked to increases in use in the population. You can see here that really there's been a rapid increase in percentage of individuals who believe there's no risk of harm from cannabis use, and this has been striking in the past 20 years or so. We also know in terms of the societal kind of context, there's been dramatic recent changes in US public opinion regarding legalization. And these have occurred really this inflection point in the last 10 years or so, in around 2010 or so, where now a majority of Americans are in support of legalizing cannabis. And I also want to highlight that there's really overwhelming majority and overwhelming support for cannabis use in terms of using medically among veterans, where 90% of individuals polled in some recent polls have shown that they support medical legalization for veterans for specific conditions like PTSD. We also know and have probably seen increases in media and advertising, especially here in Michigan. We've seen this quite a bit traveling around town. We definitely have been inundated with more and more cannabis advertising, and so that has also happened in this social context of increasing use and prevalence of cannabis use in the country. The other thing that we're well aware of is that there's been an increasing number of states passing medical, as well as now more recently recreational cannabis laws. And this is really kind of hit home in the last 10, 15 years in terms of the preponderance of states increasingly legalizing cannabis for medical and recreational purposes. So again, those are descriptive trends. I'm just kind of wanted to paint that picture and paint that contextual factors. There are empiric work in this area, but I'm not going to delve into that as deeply right now, and we can talk about that later if need be. But now I want to kind of shift and talk a little bit more about medical cannabis and how that's really relevant to veteran health, especially. So as of 2021, 36 states and 4 territories allow for the medical use of cannabis. And that's over 2/3. That means over 2/3 of the US population lives in a state with medical legislation. And you can also see that now 18 states have enacted legislation to regulate cannabis for non-medical or recreational use. And now, so that means around a third of Americans live in a state with full adult legalization. One of the interesting things to note here is that all of the 18 states that are full adult recreational, have full adult laws, had medical laws prior to their adult laws. So there haven't been any states, which is interesting maybe, that have gone full legalization first. They've always gone incrementally from first medically legal cannabis to then recreational cannabis. A lot of the state measures that have been passed, veterans and veteran organizations were major proponents of these measures, and they've done some major grassroots efforts, gotten the attention of media to support their efforts, and they help drive the movement of medical cannabis and state legalization in many ways. And so this is why I think it's important to think about the veteran community when thinking about some of these medical cannabis laws. They do vary by state, but there are generally some features or characteristics in common. And specifically, these are some of the features that are common across many of the states that have medical laws. An individual first must have one or more set of qualifying conditions that the state lay out. And then they go to a physician's office, and a physician documents that the individual has one of these conditions and signs a form, which is then submitted to the state. The state then says yes or no and sends back a card if they say yes, as verification that the patient can possess cannabis. And then the patient is allowed to either grow a small amount of cannabis or obtain it from a caregiver. And there are differences rather by whether or not a state has dispensaries versus does not have dispensaries. And so those are some features of state laws that kind of are more nuanced, that are important to think about when we think about policy, maybe some of the policy work that we do. In Michigan, our Michigan Medical Marijuana Act was approved in 2008 and effected in 2008. You can see the list of approved conditions. And we'll come back to PTSD in just a second, but then the patient can possess up to 2.5 ounces or grow 12 plants in our state. And we do have dispensaries, as we all know. The other particularly interesting thing is that PTSD was not an allowable condition under the original 2000 Act. It was added via petition in 2014 by the Michigan Medical Marijuana Review Panel. And veterans groups, again, in this instance, were really had organized grassroots efforts that were instrumental in getting this petition to the board and having it ultimately passed. And so in our state, even within our state, this issue is very, very relevant to veterans and veteran health. So when we look at what are some of the types of qualifying conditions for medical cannabis, we see that chronic pain is the overwhelming majority of individuals who seek medical certification for chronic pain conditions. And there's also other conditions that are seen in excess among the veteran population, in particular PTSD, but chronic pain is also seen in excess in the veteran patient population. This is just showing that similarly, not what we see nationally, we sort of see in Michigan as well, in terms of the distribution of the types of qualifying conditions, where severe and chronic pain is the overwhelming condition for which people receive a medical cannabis card. So when we look at medical cannabis cards or medical cannabis, we often want to think, what are some of potential medical benefits and harms of using cannabis. And this is pretty important to think about when we think about having dispensaries or having legal access to cannabis. So one of the things that I strongly urge individuals to look at is the 2017 report from the National Academy of Sciences, Engineering, and Medicine. It offers a review of this work. It summarizes the state of the evidence from that time. It's getting a little old. Now it's going to be, from what I understand, updated soon and maybe updated every 5 years or so. And there are also, just to say, there are also new reviews and evidence syntheses that are seemingly coming out on a weekly basis on a various medical cannabis condition and a various disorder. And so I think that's an interesting point to highlight. Someone may want to mute their microphone. Thanks. And then we also know that there are all of these different evidence syntheses coming out or reviews, but what we need are actual good empiric studies and randomized control trials. We need more evidence to go into those reviews to be able to say for certain or with more certainty what's helpful and what are some potential side effects of cannabis use. So I just wanted to highlight Wayne Hall's paper in the Lancet, and it kind of summarizes the state of the evidence from 2019. What I wanted to highlight is that you can see that the best evidence in terms of efficacy is for pain conditions. There is evidence for small, shorter term reductions with respect to pain in pain conditions, and maybe improvements in sleep. And so those are important to think about. But what also is important to think about in some of these evidence syntheses when we're reading them is that they sometimes combine different cannabis types or products. So there's a combination of plant-based versus synthetic products in many of these evidence syntheses, or smoked cannabis versus oral cannabis, and routes of administration are important to think about. So in the findings where we look at some of this evidence where we're looking at trials that are of mainly synthetic cannabinoids, it may not translate to the community or the population of patients who are actually using medical cannabis in the community. From our studies, where we see around 85 to 90% of individuals are using combustible whole plant products. And so that's something to think about, where the side effects may be different and potential liabilities for problems related to use may be different. And so I think we need to really keep these things straight when we're looking and evaluating the evidence in this area. Just recently, I wanted to highlight this because it came across a couple of weeks ago in the BMJ, where another systematic review and meta-analysis of randomized trials for chronic pain were looked at. And this, again, combines both cannabis or synthetic cannabinoids. And note that it's specific to non-inhaled medical cannabis or cannabinoids. And again, this may not generalize to the patient population in the US who use cannabis and primarily use cannabis in smoked form. So it's something to think about. And there's also an accompanying clinical practice guideline that's interesting to think about, because I think it's probably one of the first clinical practice guidelines that states that if standard care is not sufficient for chronic pain, they suggest offering a trial of non-inhaled medical cannabis or cannabinoids. Again, this probably does not translate to the bulk of what individuals going to dispensaries are buying. So it's really, and we're in an interesting I think, time and space in this respect. So pain obviously is very important for veterans, but PTSD is also an important area for veterans, where there's a higher prevalence of PTSD in veterans compared to the general population. And there is promise and potential for endocannabinoids as well as cannabinoids in PTSD, perhaps for sleep difficulties, or they may play a role in fear extinction. But really, with respect to the evidence regarding treatment or use to treat PTSD, it really isn't there yet. But just to say that there is potential for this, and that we need to study this more. So again, I just wanted to highlight some of the systematic reviews and evidence syntheses on these with respect to PTSD. And again, on the left, you can see that that evidence synthesis found perhaps some benefit for individuals' sleep difficulties with PTSD with synthetic cannabinoids. And again, they combine both synthetic and plant-based cannabis. What I wanted to highlight on the right is that the folks at Oregon Health Sciences University, they've done a good job of really distinguishing between some of the synthetics and some of the whole plant-based in their evidence synthesis and their reviews. They also, just to put a plug for them, is that they've developed living evidence syntheses, and I think are going to continually update some of these for the research community to really have updated state of the science on some of cannabis related trials. So I think that's a really important resource for us to have. I also, so with respect to PTSD, I also wanted to highlight the recent randomized control trial that was just published within the past year, looking at the impact of smoked cannabis versus placebo for PTSD symptoms. And it failed to detect an effect. And there were significant differences between group differences in PTSD severity scores between the treatment groups. And in fact, all 4 treatment groups, including placebo, achieved significant within subject reductions in PTSD severity scores. Which you can see here. So in placebo, there's around a 13-point reduction in PTSD symptom severity scores, which is similar across those groups. So really, we really don't have sufficient evidence to draw any firm conclusions about cannabis use as a treatment for PTSD at this point in time. So we talked about potential benefits, and there may be potential benefits, especially with respect to chronic pain, for short-term pain relief and sleep. But what are some potential harms that are associated with cannabis use? We need to acknowledge and weigh the potential harms, especially when thinking about what's happening in the community with respect to medical cannabis, where most individuals are using combustible products. And here, I should make a note that you can see some of the potential harms associated with cannabis use. I want to make a note that a lot of these studies here do not distinguish between medical and non-medical use, and individuals in these studies are generally what we would call non-medical use or recreational use, have used non-medically or recreationally. One of the specific things that I want to highlight is the development of cannabis use disorder and or the dependence syndrome. And you can see that when we talk about daily use, there is quite a substantial risk for potential development of cannabis use disorder, where those who use daily 40% of them may develop a cannabis use disorder. And that's important from a clinical perspective, because a lot of those individuals, or some of those individuals, may need treatment for that cannabis use disorder. So just so that everyone's on the same page, cannabis use disorder is a serious psychiatric condition. It involves the continued use of cannabis despite impairment in psychological, physical, and social functioning. And you can see here that you have to have 2 of 11 criteria in the DSM-5 to meet criteria for cannabis use disorder. And that's changed since the DSM-4, where we've now don't include legal problems in cannabis, what was formerly cannabis abuse. And now we also include withdrawal as well as craving as clinical features recognized in the cannabis use disorder diagnostic criteria. So again, if recent meta-analyses have shown that around 1 in 5 individuals who ever use cannabis develop a cannabis use disorder, and that conditional probability is increased if when we look at individuals who use on a more regular basis, including weekly and daily. What's different with respect to transition to substance use disorders for cannabis is that it develops more gradually than, say, cocaine use disorder, which can be seen quite frequently it develops quite rapidly. And this may be important to think about from a clinical perspective or from an individual patient perspective, that their development of cannabis use disorder may be a little bit more insidious and may not be as apparent as other types of drug use disorders. So I realize this slide is a little bit busy, but the point of this slide is to show that cannabis use disorder is highly comorbid with other psychiatric disorders. And so it's most pronounced with respect to other substance use disorders, but it's really also apparent for post-traumatic stress disorder, for mood disorders that are especially important to think about when we think about the veteran population, who may have a greater burden of comorbidities and may have a preponderance of some of these comorbidities. So that we really need to think about whether or not cannabis use is really in the best interest of individuals with co-occurring mental health disorders, and whether it exacerbates their potential problems for cannabis use or exacerbates their other psychiatric comorbidities. We also know pain is a very, very important condition among veterans, and this is a recent paper in American Journal of Psychiatry that points out that increasingly individuals with pain are more likely to develop cannabis use disorder. Any non-medical cannabis use and cannabis use disorder was more prevalent among those with pain than those without pain. And that was true in 2001, as well as in 2012 and 2013. But when considered in absolute risk terms, the differences between those with and without pain increased over time. So I think this is something to consider, especially when many individuals who are using medically are using for pain. So now I'm just going to turn to some of the recent work that I've been fortunate enough to do with some of my collaborators, and really thinking about some of the recent work that's relevant to veterans, especially some of the work that I've done or that we've done that's looked at it more in a national level or population-based level. We started with some clinic-based samples, or Mark Ilgen specifically started in some clinic-based samples in Michigan, and we've since moved to some larger population-based studies. And so I just wanted to highlight some of the key studies that we've accomplished recently. So in 2013, we were fortunate. We were looking at the National Survey on Drug Use and Health and talking, and we saw that they added a question that said, earlier you reported using marijuana in the past year. Was any of your marijuana use in the past 12 months recommended by a doctor? So this was interesting because then we could kind of start to assess whether or not individuals were using for medical or recreational purposes. And we divided those who answered yes to this question as having some medical use, and no as those who used non-medically or recreationally. So the first paper that we looked at this, Alison Lin led a few years ago, and it was one of the first national studies to look at differences between those who use medically and those who use non-medically or recreationally. What we found was that around 1 in 5 individuals who used cannabis in the past year used medically. We also found that the overall prevalence of past year medical use was around 1.1%, which translated to roughly 2.8 million adults. And then there were some key findings specifically related to those who used medically had poor health and were likely to use on a more frequent basis, more likely to use daily. So from some of these studies, I was also working with others on developing a grant proposal related to veterans and cannabis use, kind of based on kind of the social context that I talked about earlier, in thinking about the driving kind of medical cannabis legislation and the grassroots efforts. But there really wasn't a whole lot out there on cannabis use in veterans, especially at the national or population-based level or the epidemiologic study level. A lot of it was clinic-based studies. And so from there, we started developing this proposal. And as part of this proposal, I analyzed some data from the National Survey on Drug Use and Health. And one of my postdocs at the time decided to write it up as a brief report in addictive behaviors. And some of the kind of the key points here were that 9% of veterans reported past year cannabis use, so a little bit lower than the general population in terms of past year cannabis use. But what was interesting was that around 41% who reported past year cannabis use said that they were using for medical reasons, based on that question that I described earlier. And so that was a really kind of striking that veterans were using medically. It seemed greater than in the general population. So more recently, I've been involved in a couple of studies looking at NESARC3 data. And for those of you who are unfamiliar with the NESARC3 data, it's the National Epidemiologic Survey on Alcohol and Related Conditions. And in particular, they ask about DSM-5 substance use disorder and ask about DSM-5 psychiatric disorders, where the National Survey of Drug Use and Health doesn't have those diagnostic indicators in their data specific to the DSM-5. And so I was talking with some colleagues at the University of Washington, and she decided to lead a paper in the NESARC3 and did a really great job with this, specifically looking at cannabis use in veterans. And this is in press right now in the American Journal of Psychiatry, looking specifically at the prevalence and correlates of cannabis use and cannabis use disorder in US veterans. Again, so we had published that earlier paper, and this is now kind of more focused on looking at what are some of the comorbidities, especially psychiatric comorbidities associated with cannabis use and cannabis use disorder among veterans at a national level, as well as looking specifically at differences among veterans residing in states with and without medical cannabis laws at the time. And so these were kind of some key and important issues that we looked at in this specific paper. We also have a paper regarding pain and cannabis use and cannabis use disorder. I'm not going to get into that one today, but that's also in press. But I wanted to highlight this one first today for you all. So you can see here that with respect to prevalence of past year cannabis use, we found around 7% in NESARC had cannabis use in the past year. Of veterans had cannabis use in the past year. And this was slightly lower than what we found with the National Survey on Drug Use and Health. And there's different assessments, test techniques in each in the NESARC, they use interviews. And so there may be differences with respect to those types of methods, but there is relatively similar. What I wanted to highlight is some of the newer information here is that around 1 in 4 of those individuals around 1 in 4 individuals or veterans who used cannabis in the past year had a cannabis use disorder. And around 1 in 4 also used cannabis daily or almost daily among those who are in the past 12-month group. The other thing that we found similar to studies in the general population, the full NESARC sample, is that there's definitely comorbidity is more of the norm in cannabis use as well as cannabis use disorder. And you can see here that psychiatric disorders are associated with both cannabis use and cannabis use disorder in the past 12 months. And that's perhaps not surprising, but it's one of the first studies to really document this on the population level among veterans. The other thing that we did with this in this study is we looked at individuals who were, or veterans who were residing in states with medical cannabis laws versus not. And we can see that veterans, there was in states with legalized medical cannabis, the prevalence and odds of cannabis use, a daily or near daily use, cannabis use disorder, were all significantly higher than in states without medical cannabis laws. And this is also perhaps not surprising. This has been shown in some of the more general population studies. It may be that individuals in states who reside in states with medical cannabis laws were already using cannabis at a higher level than in other states, et cetera. But this is one of the first to kind of document that in the veteran specific population. And it probably, we need to think about it when we think about coming into contact with VA care, especially in states with medical cannabis laws. But, so that's some of the kind of baseline kind of descriptive epidemiology in the veteran population that was frankly, it was lacking for many years that we have collected. But there needs to be additional research that kind of goes beyond this more descriptive epidemiology and thinking a little bit more about longitudinal course, as well as thinking about how medical cannabis relates to important health outcomes, including functioning, pain, and other substance use over time. And so today I wanted to show you a little bit from a study. This isn't of veterans specifically, but it is relevant to veterans because it is a group of individuals who use medical cannabis for chronic pain conditions. And this is based on Mark's R01 that is now funding has ended, but there are still a rich data source with a lot to be done. And I may have talked to some of you about this previously, So in this longitudinal study, first patients were screened at several clinics, certification clinics, that is, in Michigan, and we developed a cohort of 801 adults who used medical cannabis for pain specifically, and they were followed every 6 months for 2 years. So we've done a lot of work cross-sectionally, both in the screening sample as well as the baseline cohort sample, and now we're doing a lot of work in the longitudinal data that has been collected. So again, I just wanted to highlight a recent longitudinal report, and this was recently published in Addiction. Lara Coughlin, who is a great postdoc at the time, who is now a faculty member in psychiatry, wrote this paper looking at the progression of cannabis withdrawal symptoms in people using medical cannabis for chronic pain. And so again, withdrawal is part of the withdrawal syndrome, is part of the cannabis use disorder criteria now. And I just want to give a little bit background specifically on withdrawal because of its importance and ramifications for clinical outcomes. And so we know that through the years, there's been pretty consistent preclinical, clinical, and epidemiologic research that documents this withdrawal syndrome. There was controversy quite a few years ago now regarding whether or not there was a withdrawal syndrome with respect to cannabis. It has been shown by Alan Bundy and others that there is, and then some of their efforts led to the addition of cannabis withdrawal syndrome to be added and included in the most recent DSM-5. So for those of you who may not be familiar with what withdrawal symptoms are, they include anxiety, sleep difficulties, decreased appetite, restlessness, depressed mood, and irritability when cannabis is given up for a period of time. And we know that there is clinical significance and clinical implications with respect to withdrawal symptoms. They're associated with impaired functioning. They're associated with difficulty reducing or stopping use, and they're associated with poorer treatment outcomes and increased likelihood of relapse. So these are important to think about when we think about cannabis use and potential problems. Again, withdrawal is now one of the criteria within the DSM-5. And you can see here that the cannabis withdrawal syndrome, you have to have 3 or more of the following symptoms after cessation of prolonged use. And you can see what they are here. They include irritability, anxiety, difficulty sleeping, restlessness, decreased appetite, depressed mood, and somatic symptoms like headache. So from national samples, we know that around 33% or a third of individuals who regularly use cannabis experience cannabis withdrawal syndrome. In prior work from Mark's studies, he's shown that around 2/3 of those who use medical cannabis report any sort of cannabis withdrawal symptoms during a period of abstinence. And although this is a really important area, there have been very few studies in general on longitudinal course of withdrawal symptoms, and very, very, very few studies with respect to individuals who use cannabis medically. So here we want to assess withdrawal symptoms over this 2-year period. First, we used a latent class analysis to empirically look at cannabis withdrawal symptom classes. And then we wanted to examine the degree of stability and change in the symptom groups over time. And so for that, we use latent transition analysis. I'll get into that in a second. So you can see here, again, we used a sample of 527 of the 801 individuals. They had to complete the marijuana withdrawal checklist at baseline, 12 months and 24 months follow-up to be included in this this analysis. This is just to highlight what the marijuana withdrawal checklist is. It asks some features, more features than what are asked in the DSM-5 cannabis withdrawal syndrome. So it's perhaps more inclusive, but it is a validated measure that was the basis for some of the DSM-5 cannabis withdrawal syndrome criteria. So for this analysis, we dichotomized each of these 15 items into whether an individual experienced them or did not. And you can see here, again, we cross-sectionally, we used latent class analysis to identify these classes or groups of individuals based on their responses to that marijuana checklist, marijuana withdrawal checklist questionnaire. And then we looked at latent transition analysis to look at how do these groups move through time. So you can see, based on the latent class analysis at baseline, we found 3 classes that were characterized by mild probabilities for symptom endorsement, more moderate probabilities for symptom endorsement, and then higher probabilities of symptom endorsement in this kind of more severe withdrawal class, if you will. And I think it's important to note that around 59% or so of individuals were in the more moderate to severe classes at baseline. So again, this is just to say, in general, the more severe classes tended to be younger, in better physical health but poor mental health, tended to use cannabis for more years, and were at greater risk for cannabis-related problems as measured by the assist. They also tended to use more frequently compared to the mild withdrawal symptom class. So from these cross-sectional latent class analysis, the next step we did is we undertook latent transition analysis to look at stability and change within and between the classes over time. And for those of you not familiar with latent transition analysis, the on diagonal is the probability of remaining in the class that you were at the previous assessment point. So you can see around the probability was around 81% of those who were in the mild class at baseline to remain in the mild class at 12 months. 14% changed from the more mild class to the moderate class at 12 months. And in general, there was more stability than there was change. The other kind of important feature to note is when people, the probabilities for moving to different classes were greater to move to a less severe class than they were to move to a more severe class over time. So this is just to say that we didn't find much with respect to predicting baseline characteristics that were associated with transitioning to a new class over time, specifically at 12 months. Just that older age was associated with lower odds of transitioning to a more severe class, and vaping was associated with lower odds of transitioning to a less severe class. So in the few moments that I have left, I'd just like to give an overall discussion, talk about some common limitations and maybe some future directions for research and some other work that I'm doing in this realm. So before I want to just to highlight some of the key points that we talked about today, including that cannabis use is increasing in the US general population and among veterans based on past year use. Around 2/3 of the US population live in states with medical cannabis laws. Around 1/3 live in states with recreational or non-medical laws. And the prevalence of cannabis use among veterans, though, is slightly lower than it is in the general population, But those who do use, it looks like a greater proportion of veterans may use medically than in the general population. And it could be relevant, especially for those with psychiatric disorders, that cannabis use and cannabis use disorder is an important thing to think about. The other kind of key point from all of this is that a majority of individuals, even those who are using medically, experience problems related to their medical use and including withdrawal symptoms. And this may be important to think about when we think about cannabis as a treatment for some of these medical conditions, that there may be some drawbacks or some unintentional harms also associated with use. Some common limitations of these data are that what I've described today is all self-reported and it's all observational data. There's really difficulty measuring the extent of cannabis use. We've often run into a ceiling effect where daily use is the highest level of use that is being assessed. But we know from other clinical studies of individuals who use cannabis, especially those who use medically, that they're using multiple times per day at different time periods in the day. And this may be important to think about when we think about both potential benefit and potential harms associated with use. We also don't have great information on strain, nor do we have great information on route of administration a lot of times. And we also don't have great information on potency. So what kinds of products individuals are using and how potent they are. The other thing to think about is generalizability with some of this data that I presented today. Some of the NESARC data is before many of the recreational laws have been passed. It's coming up here 8 years old or so now. And then also the generalizability from these medical cannabis patient populations where individuals have chronic pain, and it may not generalize to other conditions or people who don't use medically. So just some concluding thoughts. Given increased access to cannabis, legalization and use, we need to better identify at-risk individuals and understand how to minimize harms related to their use. Are there certain subgroups, including veterans, who may have a higher preponderance of mental health comorbidity? Does cannabis use exacerbate mental health problems? Does cannabis use among individuals who have psychiatric conditions, is cannabis use more problematic for those individuals? Some of the other things to think about is that we do have potential treatment for cannabis use problems, including contingency management and other treatments. But it's really better if we can try to prevent the negative sequelae and potential harms related to use from happening. So some of the other things that I've been thinking about is that we need to start studying the potential impact of cannabis use on health utilization outcomes. So how do individuals who use medically interface with the healthcare setting? I think is important to think about. Do individuals who use medical cannabis, does this affect some of their treatment adherence? Does it affect some of their treatment outcomes? Are they more likely to have poor outcomes related to their cannabis use? And then finally, can we think about ways to intervene on other ways or other qualifying conditions that aren't cannabis use? So for sleep difficulties, can we use kind of behavioral therapy for insomnia to try to impact their insomnia, but maybe impact their reliance on cannabis use, improve health and functioning. And in this way, we'll probably be better able to tease apart mechanisms related to cannabis use and these health problems in these sorts of studies. So I'll stop there because I realize I'm running short on time, but I want to give everyone a chance to ask any questions they may have. But thank you for your attention. There's my contact information, and I'm happy to take any questions now.